So let's talk about efficacy versus safety, or benefit versus risk in choosing a disease-modifying therapy. First, as you know, multiple sclerosis is an inflammatory disease of the central nervous system, which includes the brain, the optic nerves, and the spinal cord. This is a recurrent inflammatory process where each inflammatory event may last a few weeks to a few months and then resolves, only to be followed by more inflammatory events later. The therapies that we use to try to minimize this inflammatory attack on the nervous system are called disease-modifying therapies, or DMTs. There are actually 13 FDA-approved DMTs now, and that gives us a lot of choice, and as a result, we really do need to understand the potential benefits versus the risks on an individual drug level and on an individual patient level. The general strategy that we need to use in selecting disease-modifying therapies is to identify the most effective therapy for an individual patient that has the best safety profile as well, and that's also based on the individual characteristics. The key outcomes that we use to compare these agents from the clinical trials consist of three main ones. The first one is called annualized relapse rate reduction. So this is the decrease in the risk of having an attack, an MS attack, over the course of a year by being on a given drug. The second outcome measure that we need to understand and use to make these decisions is called sustained disability progression. And this is the probability that a patient over the course of a year will worsen by 1 point or more on a scale that we use in research called the EDSS scale, which is mainly related to walking. And they will stay worse by 1 point for at least 3 months. That's an indication to us that the person has lost function due to more injury occurring in the nervous system. So looking at the ability of the drugs to prevent that is an important outcome measure. And the third one is its effect on brain volume. Now, all human beings lose brain volume after about the age of 30. But in multiple sclerosis, the rate of brain volume loss is accelerated. It's up to 7 times faster than it is in age-matched controls. So we, in the modern stage, we have monitored brain volume quite sensitively in these studies. And the drugs vary in their ability to prevent brain volume loss. But the reason brain volume loss is so important to us is that that's the most powerful predictor of long-term outcomes that we have from a laboratory standpoint. So it's a valuable way to assess the ability of these drugs to prevent patients from developing further disability down the road. Now, in thinking about the therapies, given that we have 13 FDA-approved therapies, we tend to group them at the Recombined MS Center into those that we consider to be highly effective therapies. By that I mean they have greater than a 60% reduction in annualized relapse rate and greater than a 30% reduction in sustained disability progression, and similarly about a 30% reduction in brain volume loss over the first 2 years of treatment. The drugs in this particular category consist of Tysabri, Gilenya, and Lemtrada. Now, whether these drugs are exactly the same or different is not known at this time. There's not been direct head-to-head trials of these agents, but they all appear to be in the more highly effective category. The moderately effective therapies are Tecfidera and Albagio. These two drugs have somewhat less effect on annualized relapse rate. It's generally around 30% reduction or greater. And they have about a 25% reduction in sustained disability progression and about a 25% reduction in brain volume loss over, again, the first 2 years of treatment. The modestly effective therapies would include the interferons and the glutaminyl acetates. I'll go through them in a second. But these are therapies that tend to have around a 30% or less annualized relapse rate reduction, and less than a 25% reduction in sustained disability progression, and less than a 25% reduction in brain volume loss. In some of the agents, particularly the interferons, we don't yet have evidence that they actually do help decrease brain volume loss. So these are agents that we've used a lot in the past. But now that we have newer agents that have more efficacy, we tend to shift towards using more effective therapies in patients as early in the disease course as we can. Now, the drugs that exist in the modestly effective therapy category in the interferon group consist of 5 different agents. There's Avenix, Betaseron, Rebif, Extavia, and Plegridy. And these agents vary in terms of the dose of the interferon that you're getting, the route of administration, and the frequency of administration. But they all are fairly similar in terms of their effectiveness. The other group is the glutaminyl acetates, and there actually are 3 versions of that. There's Copaxone, which is injected subcutaneously daily. There's Copaxone that's injected 3 times a week. And then there's Glatopa, which is a generic version of Copaxone that was recently approved. Again, these drugs all have similar tolerability and efficacy levels. Now, from a safety standpoint, these drugs, each individual drug has its own specific safety profile. And as a result, it's important for the physicians to assess the drug in the context of an individual patient. So for example, for serious adverse effects, so these are effects of the drug that might be life-threatening or might lead you to be hospitalized. An example is Tisabri, where about half the MS population carries a virus called JC virus. And it turns out that with Tisabri, if you carry that virus, you're at risk for a very serious brain infection called PML. And that risk can be as high as 1 in 80, depending on whether you were exposed to chemotherapies early in life. And it's about 1 in 180 if you weren't. But if you're negative for that virus and you repeat that assay on an every 6-month basis, then your risk of having a serious brain infection is less than 1 in 3,000, possibly less than 1 in 10,000. Another example is Gilenya. And this is an agent that is highly effective, but the risk associated with its use is really dependent upon other characteristics of the patient, particularly other health problems. So for example, if you have diabetes and you're on Gilenya, that dramatically increases your risk of having swelling in the retina of the eye that can lead to vision loss. And if you have cardiovascular disease, such as heart block or hypertension, the drug can interact with the heart and lead to heart block and other problems. And similarly with people who have asthma or other pulmonary problems. So in terms of assessing the various risks of these patients, you have to select the patient based on their biological characteristics for the drug with the best safety profile. And if you do that, then you're able to reduce the risks of these drugs to less than 1 in 3,000 in terms of serious health problems. Now, there are also tolerability issues or minor side effects of these drugs, and those vary in frequency from almost 100% in terms of interference and causing flu-like symptoms to rashes and infusion reactions with injectable drugs. So again, they vary tremendously. But the data is reasonably accurate these days in terms of assessing the magnitude of these risks. And if you select the patient carefully, again, you can reduce the risk and also minimize the side effect profile. The other issue for maximizing safety is also close follow-up. And we call this risk mitigation programs. And for each drug, there is a specific set of tests that need to be done on a regular basis to minimize the chance that patients will suffer harm from those drugs. And so that results in a scheduled event, a schedule of clinic visits that are associated with certain blood tests or other tests that are used to monitor safety for each individual agent and to maximize benefit. So in summary, the goal of using these disease-modifying therapies is to prevent inflammation and to prevent damage to the central nervous system. And by understanding the individual characteristics of each patient and applying that knowledge to selection of these agents, we can select highly effective therapies for most patients that still have a good safety profile and will allow them to live as healthy a life as possible.